Assalamualaikum, good morning and Gongsi Fachai everyone. I'm Azlina and I'm happy to introduce our second speaker for today. Dr. Veenesh Selvaratnam is the newest member of the Joint Reconstruction Unit, Department of Orthopaedic Surgery, Faculty of Medicine. He brings with him many years of experience after training and working in various joint replacement units in the United Kingdom. Today, he will update us about one of the recent advances in arthroplasty with his presentation entitled When the Robots Take Over, Robotic Hip and Knee Replacement. I'm sure the talk is not as ominous as it sounds, but I'll let Dr. Veenesh convince you of that. Veenesh, the screen is yours.
Okay, hi, good morning, and thank you, Prof. Azlina, for the kind introduction. So good morning, everyone. Thanks for joining us today. I'm just going to talk to you about robotic hip and knee replacement. So first of all, I'm going to tell you what are the goals of this robotic in the United Kingdom in Exeter in 2018. As Prof. Azlina said, I actually studied and did all my training in the UK. I was there for about 18 years. And I was also selected for the first ever European EFORT Robotic Traveling Fellowship. I spent about 6 weeks all around Europe. My first week was in Germany, and then I went to France. And this in Nimes is very close to Marseille. It's a very nice place. And here I spent some time with Professor Pascal. And then I came back to UK and I joined Professor Haddad. He's one of the very experienced robotic surgeons. And here we were here for about 2 weeks or so. And so this is my robotic experience in the UK. And then I came back to Malaysia. And now I'll carry on with my presentation. So this is essentially the data in the US actually. So in 2018, they actually were doing about 80,000 hip and knee replacements in the UK in 2018, and 2021 they were up to 160,000 hip and knee replacements, robotic assisted. And if you have a look at it, this is the Australian Joint Registry. And if you have a look at the red line here, the conventional way of doing hip and knee replacements is going up. And this green line here, if you have a look at it here, this is the robotic hip and knee replacements, and these are going up. And it's the same in the UK, in the US, and this is the Australian Joint Registry. And all major implant companies have brought in the robotic system because this has shown tremendous improvement in patients' outcomes. So you got the Stryker, Smith & Nephew, Zimmer, and Dupuis Synthese. And now we can do total knee replacement, partial knee replacement, as well as total hip replacements. And so what are the current problems with especially knee replacement and hip replacement as well? So this joint replacement surgery is actually alignment surgery that involves bone and soft tissue. Therefore, accuracy is the key to longevity of the processes and improve patient function. And what you want to do is that you want to put the implants in the perfect position. And we think that if you put an implant in the perfect position, the implants last long. And the challenges is we know from published data, up to 20% of our knee replacements, of our total knee replacements are not very satisfied with their knees. And we think this is because patients have a higher expectancy. And we think we are not doing the proper thing for our patient, where we think the alignment is not perfect. They get some instability because of soft tissue imbalance. And sometimes the sizing of our processes is not perfect. So what is this robot? This robot is a very sophisticated preoperative planning tool and intraoperative alignment tool. This robot does not perform surgery independently. It does not make its own decision. And it doesn't do anything to the patient without the surgeon's hand. So essentially, even though it's called a robot, we are actually controlling this robot, and the robot does what we tell it to do. So in simple terms, it's a robotic arm-assisted joint replacement surgery with computer navigation. And what you want to do is every time you do a joint replacement, you want to try and hit the bullseye. So you want to get a perfect alignment. So you want to hit in the center, like this arrow. So if you have a look at it here, alignment actually matters. When you draw a straight line, you want it to be straight. And to get a straight line, sometimes you need help. And that's when the robot comes into play. And we know if you get a perfect alignment of any hip or knee replacement, it improves function, it decreases complication, and it optimizes durability. And we know if the knee component is malaligned, we get accelerated wear, you get component loosening, patients get pain, they get instabilities, they're not very happy with their knee. Sometimes you can get dislocation is what happens, if you can see in this radiograph, and patients sometimes have stiffness as well. And what happens if you get a hip wrong? You get dislocation, so it comes out of the joint. You get accelerated wear. Again, you can get component loosening. You get pain. You get leg length discrepancy, so you don't get a perfect leg length. And patients do not like this. And humans, we are not perfect. That's why we created robots to help us to be perfect. When you do a knee replacement, if you do a conventional way of knee replacement, sometimes you see x-rays like this. Sometimes patients are okay with x-rays like this, but if you look at x-rays like this, most of the time, patients are not happy. So what you want to do is you want to try and get a perfectly aligned knee replacement or a hip replacement. So why is this technology out now? It's basically an evolution of technology and is driven by orthopedic implant companies because of results from the robots, from early on from the robots as well. This technology is not new. It actually came up somewhere in 2006. So you get this kind of advertisement in the US. Basically, they said if you use a robot, it's essentially a custom-made implant or custom-made replacement. And more patients are aware of this robotic system. And if you have a look at it here, these are the searches, Google searches is constantly increasing in regards to robotic hip and knee replacement. Even in our clinic in Malaysia, now we see a lot of patients asking for this robotic hip and knee replacement. So there are three main components of this robotic system. First of all, it allows you to plan your surgery. So therefore, we think if you plan your surgery, you get more specific patient implant. You can do 3D planning either with a CT or with X-rays. And it acts like a GPS really. So intraoperatively, if you're doing something wrong, not as per your preoperative planning, the robot tells you is wrong. And some robotic system does not allow you to do any further cuts or proceed with your surgery if it's out from your preoperative planning. And obviously, with your preoperative planning, it allows you to do precise bone cuts as per your preoperative planning. So I'm going to go through robotic assisted hip replacement. So as you can see here, you can do a 3D planning and you can put the cup perfectly where you want it to go. And you can get your angles right as well. So when you get these angles, the robot puts or helps you put the implant where it's supposed to go or where you want it to go. Currently now, in most places here, we are using this old school method of templating with an acetate and with a plain radiograph. And in some centers, you've got this traditional 2D digital templating. These are okay, but it will not give you a perfect hip as every patient wants. And as a surgeon, you want to do a perfect job as well. That's when this robot comes into play. So you can pre-op plan, you can put the implant where you want it to go, you can get a perfect limb alignment, you can get a perfect limb length, and you can restore the biomechanics of the hip. The surgeon is still controlling the arm. As you do more and more of this robotic system, you will realize the robot gets it right all the time or most of the time. But still you are controlling it. And if you think something is wrong, then you replan it and you will get it right. And compared to the conventional manual methods of doing hip replacement, this robot has been shown to give you greater precision to plan. You get less bone and soft tissue damage. There's more accuracy of component positioning, and there is better bone preservation when you do a robotic hip replacement as compared to a conventional way of doing a hip replacement. And what about partial knee replacement? So you can do partial knee replacements as well. So essentially a partial knee replacement is you're basically just replacing the part which is diseased and not doing a full knee replacement like this. And in general, a partial knee replacement is advantageous in the sense it's less invasive, it's more bone conserving. You get less pain post-operatively, there's quicker recovery, better range of movement, and you feel like your knee is more normal because you're not taking off your ligaments, your ACL or your anterocruciate ligament and your posterior cruciate ligament, and you're not replacing the parts or the joints which are not diseased. But doing a unicompartmental knee replacement, it's technically more demanding or technically more difficult than doing a full joint replacement. In Malaysia, especially, this is less frequently performed. And from registries, the revision rate is higher than a total knee replacement historically. So these are the jigs that you use when you do a partial knee replacement conventionally, not with a robot. So sometimes some people eyeball it, but the thing is that you think you're getting it right, but there's nothing really telling you that you're getting it right. And we know that if you don't get it right or you don't get a perfect alignment, this is what happens. It fails. And once it fails, you end up with a big revision. You can see here, the implants, this is a conventional way of doing it. The implants are not perfect. Can you see it's bent slightly or it's malaligned? And what happens is that you get accelerated wear, it fails. Sometimes this component can dislocate as well, and you will end up with a revision. And with this robotic system, it allows you to plan your surgery. So you can put the implant where you think it is, and you can get a perfect sizing of the implant as well. And it helps you, it guides you with your bony preparation. So this is a burr, and this burr and this green thing is where you have to take the bone off. And once you burr this area and it becomes white, then you stop. And you can see this is how it's done intraoperatively. And then once you're done with all your burring, what you do is that you put your components or your trial components, and then what happens is that the robot will tell you whether it's aligned, and you can test its soft tissue as well. And if it's wrong, you can readjust it and do your bony cuts again. But as I said, once you start doing more and more of this, you've realized that most of the time, you get it perfect the first time. And this system, or this robotic system, as compared to a conventional manual way, it showed to provide improved accuracy with regards to your unicompartmental knee replacement. It reproduces implant placement. Essentially, this is a study we did in Exeter, where we looked at patients or the angles for preoperative planning. It correlated with your intraoperative planning. Essentially, what it means is that if you plan to put an implant somewhere or where you think it is right, the robot helps you to place the implant in that particular position. And post-operatively, patients get less pain. And it has been shown to patients who have got robotic-assisted joint replacement, their opioid usage is less than 50% of conventional way of doing robotic system. And you get improved functional outcomes. So your scores are better, your knee scores are better than doing a conventional way of knee replacement. And it also has shown to have lesser or lower revision rate. So the survival rate is much higher with a robotic as compared to a conventional way of doing it. And if you have a look at the joint registry in Australia, the robotic system has shown to have a lower revision rate of up to about 2%. That's quite significant. So basically, if you're doing 100 of these unicompartmental knee replacements, you're getting 2 less revision. That's quite significant. And what regards to total knee replacement, so I think most of the robotic systems have got total knee replacement softwares in. And if you have a look at it here, this is the conventional way of doing a total knee replacement, where you got all your jigs. This is your jigs to cut your tibia, and you have to make a bigger incision. There's more retraction. You need more people to assist you as well. With a robotic system, you can use a smaller incision. You don't need too much retraction, so you don't get much soft tissue damage. And again, you can plan your surgery, so you can put your implants where you think is right. You can plan your sizes as well. And what you can do is that the good thing is that it allows you dynamic joint balancing as well. So essentially, once you make your probes and you put your implants in, you can move your knee and see whether there's any laxity. If there's laxity, then you can change your bone cuts again. And again, it allows you bone precision of your bone cuts as well. And then you can trial and you can implant it. And again, you can check on your system whether you're happy with your balancing of your knee. And if you're not happy, you can go back and you can change it, and you can change your cuts. And with regards to total knee replacement compared to conventional way, so the advantages is you get improved component placement accuracy. As I said earlier on, with your hip and your unicompartmental knee replacements, patients get less pain, you get less opioid usage as well. And because you don't need too much soft tissue retraction, do not need too much assistance, you get better soft tissue protection. And the good thing is that it's also been shown to have earlier hospital discharges. And the hospital discharges are up to a day earlier with the robotic system as compared to the conventional way. And also has been shown to have improved range of movement post-operatively. And again, this is the Australian Joint Registry. If you have a look at it here, this is the conventional way. So this is the revision rate for the conventional way of doing a total knee replacement. And this is the robotic way of doing total knee replacement. Although it's not as significant as a unicompartmental knee replacement, but your revision rate is about 0.5% lower than a manual way or a conventional way of doing a total knee replacement. And this is the interesting part, again, comparative cost. So we know that doing a robotic knee replacement will be expensive intraoperatively because you need to have disposable, so you need more disposable. So intraoperatively, your cost for a robotic total knee replacement, it's slightly higher. But your total inpatient care cost goes down because patients have got earlier discharge. Their total post-operative care is lower as well because these patients, they need less analgesia, they get less complications. So the overall cost with a robotic system is actually lower. In the US, they did a study and they showed that it's probably about 2,000 USD cheaper to do a robotic system in the long term compared to a conventional way of doing a total knee replacement. So it's basically very simple. The conventional way of doing a knee replacement is like looking at your manual map. No one really does this now. And your GPS is your robotic way of doing it now. And I'm sure no one uses this manual way of doing of going to places. And now all of us are using GPS. So it's the same with robots. So I think we need to, as surgeons and doctors, we need to adapt to technology and we need to embrace technology. So basically, failing to adapt to new technology would mean denying patients meaningful technical advances. So this is the good news here. So since University Hospital or University Malaya, we are the Center of Excellence and we are the National Orthopaedic Center of Excellence. So we are hopefully going to get a robot by next month. I think we are at the final stages of our robot. So a few of us have gone for to be certified as this ROSA, as a ROSA robotic surgeon. So Prof. Azlina is here, Professor Faisal, Prof. Vivek, and myself. Everyone looks happy except me. So hopefully in the next few years or so, we can publish our data, our outcomes in our local Malaysian population as well. Thank you.
Thanks, Veenesh. Very comprehensive talk and a good introduction to robotic arthroplasty for the audience. We do have one question um, from the audience. Is from Prof. YK Chan. Maybe I'll ask the second part of the question first. Can the same robot be trained to assist in epidural insertion for the obese patient? That means, can this robot be used for other specialties?
So no, so this robot is specifically for orthopedic. So it's only for joint replacement. So currently with this robot that we are going to get, so they have got for in Malaysia we currently got only for total knee replacement, but we also got they have it for unicompartmental knee replacement and total hip replacement in other countries. So hopefully we'll get it soon. But unfortunately, it's not for other specialties. It's only for specifically for joint replacement, hip and knee replacements.
Because there are other robots in the market which non-orthopedic specialties where they can use for different aspects, but unfortunately for this particular one, it's for ortho. I guess Prof. Chan, you could maybe start to design some specialized software to assist you to do this. We look forward, if you're going to do this, we look forward to you sharing if your experiences if you go on this. She did also ask how much is the machine. I think I can, yeah, go
So,
ahead,
so,
Veenesh, in your reading.
so the machine is, I mean, they're different machines. So the most expensive one is the Mako by Stryker. So I think that's probably a more sophisticated a robot. So that robotic system you need to do a CT preoperatively. But the one we are getting is the ROSA. It's about 3 million for the robot itself, but we are getting it on loan for about 2 years. So we are not going to pay anything for the robot or for the maintenance. But we have to use the Zimmer implants, which are proven implants, and that's what we use in our normal practice anyway. So that's the cost really. So it's about 6 million to buy one. I think some of the private hospitals have got it in Malaysia. HKL Hospital Kuala Lumpur, they have got the same robotic system that we are going to get, and the same deal that we're going to get, and same with UKM as well. So there are a few robots, and the cost is different depending on which company and how sophisticated the robot is.
Okay. Any other questions from the audience? We still have some time. What are the challenges you anticipate once we start doing robotic surgery?
So I think at the initial stages, it will be basically getting your team involved. So I think when you start, I think you will. Our surgical time may be a bit longer. I suspect it'll be about 15 to 20 minutes or so for each case, just for everyone to get used to the robot. For us, for the nursing staff, for our trainees as well. And just to get a hang of it. But I think with time, I think this will help us. And I think as Prof. Azlina knows as well, in our orthopedic department, our joint reconstruction unit knows that we're going to start some day case arthroplasty hopefully in March as well. So I think in the long term, it may help us as well. This robot may help us as well with regards to patient discharges, patient getting less pain with post-operatively, and earlier discharge, less soft tissue damage. So there will be challenges, but at the same time, I think we are a hospital that is used to challenges, and I think we will be okay. I think we've got a good team. We've got good colleagues. We've got good theatre staff. We've got good management. So I think we'll be fine.
Yeah. I think that's the key, isn't it? The support from, it's not just from us within the unit, but all those who we work with is quite crucial to make sure this thing goes on smoothly.
Yes.
Still no questions, so I'll give you another one. Probably it'll be my last one.
Okay.
What's in it for the trainees? I mean, are we teaching them so advanced that they forget the conventional way, so that when they finish, they go back to KKM, they don't know how to do conventional arthroplasty? How do you think robots will help in teaching and training of our staff?
So I think first of all, I think we're not going to do with regards to the robots itself, or with regards to our hip and knee replacement, so not all our cases are going to be robotic. So we're going to do conventional way of doing hip and knee replacements as well. So I think if the robot fails, or we're not happy with the planning of the robot, and some very complex hip and knee replacements, you can't actually use the robot. And you can plan using the robot, but I don't think you can do it completely. So with regards to training and fellowships, I think it will help our trainees. They will be able to not only do conventional way of doing a hip and knee replacement, they'll also be exposed to this robotic system. And the important thing is that if you have a look at a lot of studies and the research out there, and what are the other big arthroplasty units doing worldwide, they are moving more towards robotic, because they know, and also studies have shown that it improves patients' outcome and is beneficial as well. So I think eventually, maybe in 10 years or so, all hospitals in Malaysia may be forced to use robot, or will be using robots, because they will realize that this robotic system is good and it improves patients' outcome. But even in KKM as well, well, I've heard that other big arthroplasty units up north in Alustar, where I used to work as well, they are going to get a robot as well. So I think more and more people are going to use the robot. So I think with regards to training and fellows, I think it'd be good for them. They will be able to use both methods. And the robots is basically done for primary hip replacement, knee replacement, and unicompartmental knee replacement. And our revisions, we don't use the robotic system, so our revisions are still manual and the conventional way of doing it. So I think you need to know your conventional way, because that's where you're going to fall back if you're not very happy with the robot, or you don't trust the robot. But as I said, once we start using the robot, we'll realize that this robot is actually good, and you have to just trust the robot and just do it, and it'll be fine.
Okay. So you mentioned something about revision surgery, because there is a new question. Um, you've said that we don't use it for revision surgery, and the follow-up to it was why not. But I think it's boils down to the limitations of what the robot can do. I think probably at this current stage, correct me if I'm wrong, Veenesh, at this current stage of technology and where we're at, probably it's not possible to do it very accurately. But I assume in future, the algorithms will be improved, that we will be able to do revisions, and we should not take too long.
Yeah, that's right. I think Prof is right. Yeah. So I think the thing is that with revisions, the simple revisions like converting a unicompartmental to a total knee replacement, we can still do it with the robotic system. But some of the really bad, I mean, we see a lot, or we do a lot of bad ones in UM, because we are one of the referral centers, one of the tertiary referral centers. So some of the really bad ones, the robot, we don't have a software to actually do the full revisions for these, because they don't have the software. But I'm sure with time they will find something with technology, with evolving technology. They will find new softwares, and we may be able to do a more complex revisions robotic assisted.
Yeah, I think just to add on to it, because when it comes to redoing a surgery, if it's just very minor bone loss with minimal soft tissue damage or injury, it's probably doable, correct? But when you are seeing some of the cases that we do here, where maybe a third of the bone is missing, and along with all the soft tissues, I think the robot just can't get it in its head to figure it out. But again, we think that with time, with better understanding, we got lots of clever people out there trying to program stuff. I'm sure they'll overcome this over time. Another question, I'm not sure, I don't think you'll be able to answer this. I'll probably will have to help you. How would the procedures be done with assistance of a robot be covered medical legally? Do you need to get extra insurance cover? Medical legally, I think it's not a problem. It's similar to navigation, how we did before. You don't need to be covered per se, but I think in this day and age where people are concerned, even industry is concerned, they will not let a surgeon touch the robot unless you've gone for training. So the training is essential. One is so that you do the best for your patient with the robot. Number two is you don't rosakkan the robot and blame it on technology. You do not need to get extra insurance cover for this case. And I think in terms of the fee schedule, there is a provision within the fee schedule to add on fees if you're using technology assisted surgery, like navigation or robot, that you add on top of your primary surgery fees. I think I'll leave it at that. The last, probably last question for this session for Veenesh: should we maybe not call it robotic to avoid the misconception of patients going on a conveyor belt?
So should we not call it robotic? You said,
Yeah, don't call it robotic. Call it something else.
No, but
Or else patients think they're on this assembly line.
I know. So actually, the real term is actually robotic assisted hip and knee replacement. But I think a lot of people try and market it. I mean, this is all just marketing, really. So to call it something fancy, because everyone's saying, oh, robot means it must be good, but they forget to realize that it's actually humans that actually invented robots. So
that's what they
so
say in
ideally
Terminator too,
yeah. So I think calling it, I mean, what else can we call it then? So the thing is that we call it robotic just to make it sound a bit more fancy, but actually it's robotic assisted hip and knee replacement. As I said earlier on, the robot doesn't do anything without planning or without us telling it what to do or without us agreeing to what's it going to do.
Okay,
so it's still under our control, under the surgeon's control.
So maybe at least for our side to call it robotic assisted. I think for patients they like the idea of robots because they think, wow, so advanced. Okay. All right. Thanks so much, Veenesh, for sharing with us this morning. Thanks everyone for joining us. I hope you have a good day, good week, and see you all next time. Bye.
All right. Thank you. Have a good day. Bye.
Bye.